Yeah, I think we're good to go now, Pete.
Okay, thank you. Hello, good evening and welcome. My name is Pete Sagar, and on behalf of my co-chairman Kai Long, it gives me great pleasure to introduce you to the ASGBI Centenary Free Paper Series. We've got a series of short papers to start off with. The presenters have been asked to keep these very short, so they've each got 3 minutes to present. We'll have 2 minutes of questions, and please feel free to send your questions in either through the Q&A button or the chat button for each of the presenters. To start off with, it's a great pleasure to welcome Adil Shafi, who's going to talk on the topic of preoperative optimization of patients with iron infusion prior to a colorectal resection. Adil.
Hello, how are we doing, everyone? So, just to start off my presentation, we're going to talk about preoperative optimization with pharyngeal use in elective colorectal cancer resections. Next slide, please. So this was a retrospective study from November 2016 to August 2019 at Furness General Hospital. We had exclusion criteria of benign pathology, pharyngect that was given post-operatively, or blood transfusions that were given pre-pharyngect, and any patients that had an adverse reaction to pharyngect itself. Primary objectives of this audit were requirement for blood transfusions, patient length of stay, and a rate of complications. So the data group that we had 83 patients in total. 4 of these patients were excluded for reasons listed below, which left us with 79 patients. 39 of these patients had pharyngect, and 40 of these patients did not have pharyngect. 49 males to 30 females, and age ranged from 30 to 87. Next slide, please. So just looking at the data itself, when it comes down to transfusion, in the pharyngect group, there were 5 patients that required a transfusion in the pharyngect group out of 39, and in the no pharyngect group, there was 11 patients that required a blood transfusion, and I think 28 units total in the no pharyngect group and 17 units total in the pharyngect group. When we looked at length of stay, there was no real difference between the 2 groups, but we could be stretched to say, that's very small to see that writing there, sorry. We could be stretched to say that there was less time stayed in the pharyngect group, and a mean of 5.5 compared to 6. And when we compare complications, there was 6 in the pharyngect group and 8 in the no pharyngect group. The 6 in the pharyngect group included things like a UTI, post-operative ileus, pyrexia of unknown origin, and a wound infection. But in the no pharyngect group, they were slightly more complex with things like an NSTEMI, a relaparotomy, and even a death as well. Just on to the next slide, please. So just looking at the outcomes of these patients, in the pharyngect group, there was a 12.8% requirement for red blood cell transfusion, and in the no pharyngect group, 27.5% requirement. That gave us an absolute risk reduction of 14.7% for transfusion and a relative risk of 0.47. Absolute risk reduction of 5% with use of pharyngect in complication rates. And we did have standards set out for this audit, so I've just mentioned them at the bottom. We looked at requirements for 100% of patients who are given pharyngect should have iron deficiency anemia. And yes, 100% of our patients did have iron deficiency anemia that were given pharyngect. And 100% of our patients, we said, should not be transfused unless their HB falls below 70. Unfortunately, only 40% of our patients met that criteria, and the reasons were a bit unclear due to poor documentation. And then finally, 100% of our patients should not exceed 7 days post-operative stay, and we were quite good there. 79% of our patients met that criteria. Final slide, please. And then just in summary, we set out to see if it made a difference, and I think we could say that it does. So preoperative use of pharyngect in iron deficiency anemia patients undergoing elective colorectal cancer resections optimizes 1, length of stay, 2, requirement for blood transfusions, and 3, rate and potentially severity of complications. And most importantly, it improves patient well-being. And then last slide, just for acknowledgements and references. Thank you very much.
Thanks, Al. When did you give the pharyngect? How soon before the surgery? And how easy was it to organise the pharyngect? Did you have a service commitment from a nurse or from a technician?
Yeah, so did vary between a few months to up to a couple of days before the operation. And in Furness General Hospital, it was really good. We had a surgical assessment unit in which patients could be referred from clinic or even arranged to come back at a later date, and they would be able to come to the surgical assessment unit, and we had a stock of Ferinject on the ward, so there's no waiting around. They could just come in anytime they wanted to, have their Ferinject, and then go home the same day.
And the level of cut-off to give Ferinject, what level of hemoglobin or ferritin did you use?
Ferritin, I can't remember the exact figure off my head, but I think most of our patients, about 85%, had ferritin less than 30.
And HB?
HB varied. Some patients had a normal HB, but obviously their ferritin was low. Okay. So yeah.
Super. Thank you very much.
No worries.
Okay, thank you very much, Adil. So the next one, can I invite Andrew Cameron, who is going to talk to us about colorectal cancer incidence after cessation of colonic polyp surveillance for patients over the age of 75. Andrew, all yours.
Good evening. My name is Andrew Cameron. I'm a surgical trainee in the west of Scotland, and I'm going to be presenting data from Lanarkshire pertaining to the incidence of colorectal cancer following the cessation of routine endoscopic surveillance for polyps. Next slide, please. This study was prompted really by the updated guidance published earlier this year by the British Society of Gastroenterology and ACP-GBI, one element of which was suggesting that if felt clinically appropriate, there would be limited benefit in continuing surveillance for patients who are aged 75 years or older, or in patients for whom the life expectancy was likely to be 5 years or less. Limited benefit both for the financial cost saving to the healthcare providers and to the quality of life years gained by the patients. There was a realisation that the 75-year cut-off reflected the standard of care that had been in place in Lanarkshire for a number of years, and that we had access to a large cohort of patients whose outcomes could be analysed to give us an up-to-date picture of the colorectal cancer incidence. So the primary objective was to work out how many patients had undergone investigations after their surveillance had stopped, and what was the incidence of colorectal cancer in this group. Next slide, please. So the methodology was fairly simple. It was a retrospective analysis of a prospectively collected database. So we had every patient who'd undergone colonic polyp surveillance, and we identified all those who'd been removed because they were age 75 years or older. Their records were, the electronic patient records were reviewed to establish anyone who'd had a colorectal investigation, which was defined as either a colonoscopy, a CT colonography, or a CT abdomen and pelvis. They were then cross-referenced with our local and tertiary colorectal MDT for registration to establish which patients had a formal diagnosis of colorectal cancer. And the final slide, please. So review of results. So 682 patients identified who were removed from surveillance between 2012 and 2017, with a median follow-up of 69 months, so greater than 5 years. Of these patients, about 19% had a CT scan at some point after the cessation of their surveillance. 40 patients, representing 5.9%, had a further colonoscopy. As subsequent to this, 19 patients of the 682 had a registered diagnosis of colorectal cancer. And to put that into perspective, that would represent about 1.8% of the total colorectal cancer burden in this age in this population. Of these 19, at the time of analysis in 2019, only 4 patients had undergone surgical resection with the intention of curative intent. In summary, our findings would support the most recent BSG recommendations that if the polyp surveillance programs are stopped, that a proportion of cancers will be missed, and this may be approximately 2% of their total colorectal cancer burden, but given the low curative yield, that ongoing surveillance is probably not supported.
Thank you. I see there's no question coming from either the Q&A or chat button, so I'm going to kick off with my question.
Yep.
Do you think you could have, your study may have underreported the incidence of colorectal cancer in the cohort, particularly the ones that you don't follow up with any imaging or surveillance?
I think almost certainly, and I think there will almost certainly be a group of patients for whom either investigation was felt not appropriate or patients who declined further investigation. And I suppose depending on at what stage that happens, whether that happens in primary care or initially in clinic, and with the standard of documentation, that was quite difficult to establish. I suppose the other limiting factor is that this was only focused on the data from one health board. So if patients moved either to other parts of the UK or moved abroad, then we wouldn't necessarily have that data. So I think you're right. I think we almost certainly are underestimating, but I suppose even if you took that into account, you'd still be looking at a relatively low proportion of patients.
Okay, thank you very much.
Thanks, Kai. Next presenter is Judith Johnston, who's going to talk on Z-plasty to manage colostomy stenosis in high-risk patients. Judith.
Good evening. My name is Judith Johnston, and thank you for this opportunity to present at this year's virtual ASGBI session. Approximately 13,500 people in the United Kingdom undergo surgery, which results in the creation of a stoma each year. And unfortunately, issues do arise. Stomal stenosis is a late complication which constricts the lumen of the stoma and affects between 2 and 14% of patients. This can occur at either a fascial or a cutaneous level, with patients complaining of difficulty passing stools, thin stools, pain, and intermittent obstructive symptoms. Management of stomal stenosis is stepwise, starting with laxatives and a low residue diet. Dilatation has limited use, and some studies suggest that it may in fact exacerbate the issue. The definitive management of stomal stenosis is operative, and most require laparotomy or translocation. Many patients who have stoma created are comorbid and frail. These are the patients that have complex treatment needs secondary to either inflammatory disease or to cancers. These are often the patients in whom primary anastomosis is deemed too precarious. It follows then a significant operation, often within a short timescale, that pose significant risk. Z-plasty is a technique extracted from plastic surgery, where it is commonly used to improve the function and appearance of scars. It comprises of 2 opposing translocational flaps which bring together in tissue from laxity. It was first documented as a treatment for stomal stenosis by Lyons back in 1960, but has lost popularity in recent years. The steps are, demonstrated in the slide, first, through the bowel to the fascial level with an elliptical incision incorporating the cutaneous portion, was the previous slide, sorry. Secondly, refresh the stenotic bowel as required. Thirdly, secure the skin edges. Fourthly, perform the Z-plasty incisions in both the bowel and skin. Penultimately, transpose the bowel and skin flaps into the appropriate apices. Finally, close the skin incision and apply the stoma bag. As there's no intra-abdominal component to this operation, there is the scope to perform it under local block or local infiltration. I'd say next slide, please, but I think we've skipped to your head. Thank you. As you can see from this patient, preoperatively, the lumen would not even allow passage of a swab, while intraoperatively, the stoma looks rather unappealing. By 3 months, the stoma is healthy with a normal caliber of lumen. This time, next slide, please. Within the Mid Yorkshire Trust, we have a case series of 5 patients who have undergone this operation from 2009 to 2019. With an average ASA of 3 and initial operations predominantly for cancer, these patients are again comorbid and frail. However, the median operative length was 50 minutes, and patients were discharged at 3 days with no complications. None of the patients involved in our case series required further intervention for stomal stenosis or other management of their stoma. In summary, Z-plasty for stomal stenosis is a safe and effective management.
Thanks very much. A lot of these stenotic colostomies are actually because of retraction. So how much retraction do you think there was there in terms of the stoma falling away from the skin? And did you incorporate that in the Z-plasty in order to get a healthy mucocutaneous junction fashioned?
So all of our patients in our case series had problems with ischemia post-operatively with their stomas, We found that that was the reason behind their stenosis. Obviously, there was an element of retraction within that, but able to incorporate the elliptical incision at the beginning, we didn't find that we had to delve down to try and free up any more length.
So you didn't need to enter the peritoneal cavity in any of the patients?
No.
Well, that was good. No, nice little technique. Okay, thank you very much, Judith.
Thank you.
Kai.
Thank you very much, Peter. So can I invite Jordan Fletcher next, who will be talking to us about the impact, it's quite interesting, impact of three-dimensional recon and standardized CT interpretation. I've just said Amigo. He's going to talk to us about this. Jordan, all yours?
Yes, thank you. Can you hear me? Yeah, my name is Jordan. I'm one of the research fellows down at St. Mark's. And this study is looking at the effect of 3D models on anatomical understanding of mesenteric vascular anatomy, mainly relating to complete mesocolic excision surgery. So CME surgery represents a more radical resection than a traditional hemicolectomy, but one of the principal difficulties is the complex, highly variable vascular anatomy, particularly for right-sided lesions. So preoperative planning and getting a conceptualization of the patient's anatomy is essential. So next slide. Is it a video should be playing now? Click again. Okay, so the video's failed, but we're able to reconstruct, we're able to take patients' anatomy and use open source software named ITK Snap to produce high definition virtual 3D models, which can be manipulated in 3D in real time and visualized on a web-based platform. So we recruited 13 participants who were divided into groups of 6 and 7 based on the day they attended the study. We had 15 CT scans from retrospective CME cases, and the anatomy was confirmed following review by 2 GI radiologists by consensus. Participants received a CME anatomy manual prior to attendance, and during the study day, they had workshops in CME vascular anatomy and also training in the Amigo method, which is a standardized approach to interpreting a 2D CT scan. And finally, basic training on how to use the 3D models appropriately. The primary outcome measure was an objective mesenteric vascular anatomy score, which was derived from a custom multiple choice questionnaire. There were 3 rounds of testing. So after the basic anatomical training and following the Amigo and finally using 3D models, each of the 15 patients was randomly assigned to each round of testing for each of the participants using a random sequence generator. Next slide. So as you can see, both Amigo and 3D models significantly improved the trainee performance from baseline, with 3D models outperforming both Amigo and baseline performance significantly. Next slide. If we look at the subgroups, and the only difference here was the order in which they undertook each workshop, we see that in group 1, which consisted of baseline testing, Amigo workshop, and then 3D models, the 3D models outperformed both. However, in the second group, there was no statistical difference between the Amigo method and the use of 3D models. Next slide. If we look at the performance by the specific case, we see that 3D generally outperformed all of the methods in all but one of cases. Next slide. And 11 out of 13 candidates performed best using 3D models. Next slide. We can see from, sorry, the formatting on these slides is all wrong, but our study demonstrates that 3D models improved anatomical understanding of mesenteric vascular anatomy in a group of senior general surgical trainees. We feel that 3D models may be a useful adjunct to help planning CME surgery. And as next steps, we need to prospectively validate the reconstruction methods and also evaluate the clinical utility, as well as evaluating whether this improved anatomical understanding is present in expert practitioners rather than surgical trainees. Thank you.
Thank you very much, Jordan. Can I ask you a little bit more about the training? What does it involve? Is it a 2-hour teaching session?
So
Is it
the anatomical workshop was a 90-minute seminar consisting, so they received an illustrated manual demonstrating all the variants of vascular anatomy that we find with some custom illustrations that I did. And on the day, we showed operative videos as well as illustrations, and we detailed the kind of, it was an anatomical tutorial relating to variants in colonic vascular anatomy. The Amigo workshop consisted of detailing the Amigo method itself, as well as an opportunity to do hands-on practice that lasted around 60 minutes. And for the 3D training, that only consisted of 5 to 10 minutes of just basically how to orientate the models, just, how to manipulate them in 3D space, how to zoom in, how to hide certain elements. So it was just a kind of user interface tutorial.
And do you screen your test subjects about their knowledge about CT scan prior to putting them through the training?
No, we asked them whether they had any formal training in CT interpretation, and all the members just had basically informal on-the-job training. So we assumed there was a kind of baseline performance there. One of the candidates had a father who was a radiologist, so I don't know if she had a slightly maybe more experience, but the kind of level of prior experience with CT was the same for all candidates, and none of them had really looked specifically for vascular configuration. So we assumed there was a baseline there.
Thank you very much, Jordan. Back to you, Peter.
Thank you. Next speaker is Danilo Yershov, who's going to address the topical topic of sarcopenia and its effect on outcomes after lap rectal surgery. Danilo.
Thank you. Good evening. My name is Danilo Yershov. Thank you for inviting me to present our project, Sarcopenia and the Clinical Pathological Outcomes in Laparoscopic Rectal Surgery. As everyone knows, colorectal cancer is the second most common cause of cancer death in the UK. Sarcopenia is defined by the presence of low muscle mass. It is associated with the outcomes of colorectal cancer surgery. While radiologically determined sarcopenia is associated with poorer outcomes from chemoradiotherapy, there were no studies on its effect on minimally invasive rectal surgery. We therefore examined the relationship of sarcopenia, low muscle mass, with the clinical pathological outcomes of laparoscopic rectal cancer surgery. Next slide, please. We searched the prospectively accrued database of our department to identify patients who had rectal cancer resections in the past 2 years. Of the 90 rectal cancer patients, 45 underwent laparoscopic resections and were included in the study. The data on clinical pathological outcomes were collected. The CT scans were examined retrospectively to determine the sarcopenia scores of individual patients. Housefield unit average calculation of the area of both psoas muscles was measured for the individuals. The results were divided into 4 quartiles and graded from 1 to 4. Grade 1 and 2 represented patients who were sarcopenic in comparison to the rest of the cohort. Next slide, please. Oh, sorry about the formatting, I'm not sure what went wrong. So these are the results. The low sarcopenia scores 2 or less. This means patients with sarcopenia, those patients were associated with preoperatively associated with age, WHO performance status, and type 2 diabetes mellitus. Post-operatively, patients with sarcopenia were correlated to Clive-Dinder morbidity scores of 2 or more and conversion to open surgery. Interestingly, patients with sarcopenia were more likely to have a higher TME grade. Next slide, please. Sarcopenia, in conclusion, sarcopenia is a useful marker in laparoscopic rectal cancer resections. It requires further evaluation towards improving model predictions of surgical outcomes. Thank you for your attention.
Thanks, Donald. Just clarify what you meant by patients with low sarcopenia score would have a higher TME grading. Why do you think that was the case?
Well, we don't know for sure, but we hypothesized that possibly patients with low muscle mass and smaller psoas muscles would have more space in the pelvis, which would make operation easier in terms of achieving higher TME grade. The other hypothesis was that those patients who had sarcopenia had high conversion rate. So possibly surgeons operating on them had more expertise in performing open anterior resection rather than laparoscopic ones, which yielded greater grade.
And you mentioned there were 45 patients who had rectal cancer by open surgery. Do you look at their outcomes as well? I know you didn't present the data, but did you look at the outcomes?
No, we only explored the laparoscopic resections.
Might worth looking at those. Okay, Danilo, thank you very much.
Thank you.
Kai.
Thank you very much. Next, can I introduce Moise Shah, who will be talking to us about restorative proctocolectomy for pediatric IBD, as it's a very long year of follow-up series. Off to you, Moise.
Thank you. Yeah, so my name is Moise, and I'll be looking for a few minutes on restorative proctocolectomy for pediatric IBD. And this is a series of cases over 10 years in a large center in Glasgow. And before I begin, I'll just give some rationale as to why we did this study. So ileoanal pouch surgery is offered as a means of stoma saving as opposed to having one, and to improve the quality of life, and so that the patients can have a degree of continence that is near normality. So we carried this out to review the indications, morbidity, and mortality, if any, in patients being offered this in the pediatric population who have IBD. So next slide, please. And we did a retrospective analysis, a review, as I said, of the indications, outcomes, and morbidity in the pediatric population undergoing ileal pouch anal anastomosis, with pouch failure defined as excision of the pouch within 1 year or presence of an unreversed stoma within 1 year after its creation. Next slide, please. And so we had 28 cases with a median age of 12.5 years. 3-stage process was undertaken for 27 of the cases, and 1 was carried out in 2-stage, and the indication for that was familial adenomatous polyposis. The vast majority of cases were carried out for ulcerative colitis, 3 later shown to be Crohn's disease on pathology, and 1 for eosinophilic colitis, and 2 for FAP. All of the patients underwent at least a 2-stage process, with all being defunctioned with a mean time to reversal in 170 days and a median inpatient stay of 9 days. Now, the reason why we did it, to identify complications, was to identify the morbidity incurred from this. So within 30 days, we had 1 herniation of small bowel with requiring re-laparotomy, and 1 patient who had a bleed requiring transfusion and subsequent EUA and washout. Long term, we had 4 additional small bowel obstructions, 2 managed conservatively and 2 requiring laparotomy, and 3 pouch anal stenosis requiring dilatation. 2 patients with Crohn's disease had enterocutaneous fistula and pouch vaginal fistula, and 4 episodes of pouchitis, 1 pelvic sepsis, and no pouch failure as per our definition, no anastomotic leak. However, 2 pouches were excised, both related to Crohn's disease. Next slide. So we incurred low morbidity with no instances of anastomotic leak. However, as I said at the beginning, the reason why we do this is to identify the functional outcomes and whether or not this makes a difference to quality of life outcomes. And so the next stage for this project is to undertake a functional survey of our patients following ethics approval. And the future of this procedure perhaps lies in the transcutaneous evacuation system. Trials are currently undergoing in Sweden and America. Thank you.
Thank you very much, boys. So what do you think then are the other parameters or measures that is important when looking at outcomes following restorative surgery for this young cohort of patients?
So yeah, you quite rightly asked that. We've simply just looked at the complications without looking specifically at, as you say, the functional outcomes. So things like, now this is a pediatric population, but we also have an ongoing study in the adult population, things like continence, number of times needing to move their bowels per day. Can they have a normal social life? For example, some surveys have found that 37% of adults who underwent IPA surgery had no change to their lifestyle, and 31% only a small change to their social life, and not able to actually have a normal level of continence. So I think definitely the parameters we want to look at are the functional outcomes. Does this make a difference to the quality of life of the patient, as opposed to incidences of things like pelvic sepsis, which are important, but I think the quality of life parameters are more important.
Okay, thank you very much. Peter?
Thank you.
Thank you, Kai. Okay, the next presenter is Tanvir Abbas, who's going to talk about psoas muscle index and skeletal muscle index and the outcomes from operable colorectal cancer. Tanvir.
Mute. Yeah, thank you for the opportunity. And this project is basically looking at the low skeletal muscle index and comparing it and measuring all the skeletal muscles at lumbar 3 level as compared to using only psoas muscles at L3 level, and comparing its relationship with the clinical outcomes in patients undergoing colorectal cancer surgery. Next slide, please. So we had a population of around, we had over a 10-year period, 1,047 patients, in which we excluded around patients with stage 4 cancer, giving a sample size of around 1,002 patients for patients with operable colorectal cancer. These patients who had a CT scans performed as a part of staging scan within about 3 months of the surgery were included in this study. Their skeletal muscle index was calculated by using image J, which I will point to next slide. Image J and these pre-op scans were calculated, and we calculated their area of skeletal muscle index as well as psoas muscle index. The background is basically the sarcopenia, which is indicated by low skeletal muscle index, can be calculated by using all the muscles at L3 level or psoas muscle. And the psoas muscle is much more kind of less time consuming, but the questions have been raised about the validity and use of it as a measure of sarcopenia in the patients. So the skeletal muscle area and psoas muscle area, which we calculated, was normalized for the height in meters square, and we calculated skeletal muscle index and the psoas muscle index in these patients. These patients were further classified by using area under curve and using SPSS to calculate the optimal threshold in order to classify them whether they have got low SMI or low psoas muscle index, low PMI. And further multivariate and univariate logistic regression analysis was carried out by taking into consideration the patient's clinical characteristics like age, TNM staging, BMI, and as well as the skeletal muscle index and the psoas muscle index. Next slide, please. So this is how we calculated it. So basically two of the researchers, me and one of the medical students, carried out independently the analysis on image J and using the pre-op CT scans. And the picture above shows the psoas muscle index, in which we highlighted the skeletal muscles, anterior abdominal wall, lateral, and paraspinal muscles, and got the skeletal muscle area from there, and which was normalized for height in meters square to give a skeletal muscle index. And the picture below shows the psoas muscle area, which has been highlighted using image J, and both of the psoas muscles, they were added in order to get the total psoas muscle area, which was normalized for height in meters square to get the psoas muscle index. And we also calculated the relationship between the psoas muscle and skeletal muscle area using Spearman correlation, and found a moderate correlation with R value of 0.71. Next slide, please. Regarding the results of the study of a sample size of 1,002 over a 10-year period, we identified that in this operable colorectal cancer, about 50% had a low SMI and 42% had a low skeletal muscle index. On univariate analysis on logistic regression, a low skeletal muscle index was associated with prolonged hospital stay and overall, and a shorter 3-year overall survival with p-value of less than 0.001. On multivariate analysis, by taking into consideration the other clinical factors like age, BMI, and TNM staging, and the low SMI was still significantly independently associated with prolonged length of hospital stay, which was defined as a length of stay of more than 7 days. With regard to the low psoas muscle index, on univariate analysis was associated with prolonged length of hospital stay and also shorter 3-year overall survival with the p-value of less than 0.01. However, on multivariate analysis, by taking into consideration the other clinical characteristics of patient, low psoas muscle index was not independently significant. Next slide, please. In conclusion, ladies and gentlemen, this study shows that total skeletal muscle and source muscle index, they are directly associated, and they are moderately related with each other and had a prognostic value. However, with regard to the independent prognostic value, total skeletal muscle index stands high with regard to independent prognostic value in patients with operable colorectal cancer. So in these patients, measuring sarcopenia, total skeletal muscle index gives much broader value, and many muscles are analyzed in order to define low SMI as compared to just one source major muscle. Thanks for the opportunity, and that's the end of presentation. Any question, please?
Thank you. This may show my ignorance, but you can tell the difference between fatty muscle and non-fatty muscle on the CT scans, correct?
Yes.
So you're not looking at necessarily people got a fat in the psoas muscle, and that's not skewing your results. Is that correct?
In this study, we looked at the indices, and because the fat in muscles, like the term myositis, it is influenced by various other factors like phase of the scan as well as cardiac output of patient, and the anatomical basis is not well correlated. So for the purpose of this study, we concentrated on muscle areas only.
Okay, super. Thank you very much. Kai.
Thank you. So the next speaker is Lava Kanapa, and he will be talking to us about microRNAs as a predictive tool for response to therapy. Off to you, Lava. We can't hear you. Just in case you're on mute, can you unmute? Still nothing, Lava?
Can you hear me now?
Yes, yes.
Oh, thank you so much. Hi, Kai. So this is just a snapshot of my MD, a lab work which I did in University of Leicester. So next slide, please. Thank you so much. So this all revolves around biomarkers in colorectal cancer. So if you look at it there, National Institute of Health defines a biomarker as some sort of a biological molecule found in blood and fluids like urine, plasma, saliva, which is associated with abnormal process of a condition or a disease. Mostly these are refers to DNA, RNA, anything to do at cellular level. And you also need to think about the tumor markers, which are mostly proteins and glycolipids, like CA and fecal hemoglobins. Next slide, please. Thank you so much. Okay, what are microRNAs? These are small RNAs, much shorter than the normal RNAs. It consists of about 17 to 25 nucleotides in relative comparison to the RNAs, which are like 80 to 90. And they participate in gene regulation and transcription. And these could be picked up in plasma, saliva, blood, urine. Okay, next slide, please. Thank you. So basically what we did was, I think one of the slides are missing. So basically, okay, that's okay. So what we did was we screened 100 patients of colorectal cancer, and we took pre-treatment sample bloods, and then these were followed up after the treatment. When I mean treatment, it means surgery, chemotherapy, radiotherapy. They were followed up over a period of time, and we took blood samples post-treatment. And then, so initially in our lab, we did test the microRNAs and showed to the world that microRNAs can differentiate between normal tissue, adenomas, and adenocarcinomas. Mine was just a follow-up. So we took the pre-sample, post-sample, compared the blood samples, and checked into the microRNAs. So we showed there were 3 microRNAs where the levels were increased when they were cancerous, and when they were cured post-treatment, confirmed by CTs and the colonoscopies, these levels decreased. And we also looked into the specific matched variables like Dukes and TNM, node status, CL levels, age, male, female, and we did a multiple linear regression as well. Next slide, please. Right. So of the 3 microRNAs we introduced to the world, which had a high levels when they were cancerous, they also showed one of the microRNAs, microRNA 135, or also can disparate between the node status as well, positive, negative, and also the number of nodes involved as well. Next slide, please. Thank you so much. So despite the initial pre-treatment recruitment of almost 100, we could recruit a matched samples of only 32. That's because many of them died, and then some people didn't come for the follow-up, and some of the samples are too little for the pre-treatment samples, which we couldn't get it. So statistical analysis, we did robust statistical analysis. The data was non-normalized data. So we used a non-parametric test with multiple linear regressions. In conclusion, what I can say is University of Leicester introduced 3 microRNAs, which are very specific to colorectal cancer. And by far in the literature today, this is one of the largest studies in the world. Thank you.
Thank you, Lava. Do you know, or do you have a hypothesis as how these microRNAs levels go up and down based on the treatment? Is this just a random effect, or is there an underlying mechanism?
Yeah, so basically, microRNAs are, once they are released from inside the nucleus to outside, they are in a lipid vesicle, safe. They are bound in lipid vesicles, which are safe and which are not, which cannot lyse by itself because of the proteins, because of the enzymes, and which could be picked up in the bloods as well. So, so that could be picked up in the plasma and the urine. And if you look at the yields of microRNA, the cell lines has about 1,000 nanograms of microRNA. Next comes the plasma and the blood, about 100 nanograms. The urine and the saliva the yield is about 10 nanograms of microRNA.
Okay, thank you.
Thank you.
Thank you very much. Okay, from the complex, the more simple. The last paper in the short paper section is going to be presented by Malaz Abakar on the appendicitis inflammatory response, an attempt to stratify patients with appendicitis.
Hello, hi, my name is Malaz. I'm one of the CT doctors in Scarborough Hospital. I'm going to talk today about appendicitis inflammatory response score. Can low-risk patients be safely managed on an ambulatory care basis? So we know that right iliac fossa pain and suspected appendicitis is one of the most common presentation to the emergency department, and diagnosis of appendicitis can sometimes be challenging, hence why we have multiple scoring systems that are available, the oldest of which is the Alvarado score. However, we chose to study the AIR score, which is newly proposed in 2008 scoring system for the appendicitis. Next slide, please. So the AIR score is more discriminatory than the Alvarado score in the diagnosis of acute appendicitis. Particularly, it has a higher sensitivity in ruling out appendicitis in the low risk group and more specificity in ruling in appendicitis in the high risk group. We studied the utility of the AIR score in reducing admissions and the number of investigations and intervention without unnecessary risk to the patient. Our method was, it was a retrospective case review for patients with right iliac fossa pain. They had the AIR score calculated, and then the low risk group identified with a score less than 4 or less, sorry. And then we analyzed the inpatient cost of beds, imaging, intervention such as laparoscopy, and all of these costs were determined by the NHS National Tariff Payment for the past 2 years. Next slide, please. We had in total 171 patients, of which 68 had a low risk score. The median age was 22.5 years, and male to female ratio was 1 to 2.2, and total bed stay of the low risk group was in total 167. The median length of stay was 2.5 days, the longest of which was 11 days. 71 of, for the patients, they had 71 diagnostic imaging, 56 ultrasound, of which 39 were normal, 10 showed gynecological pathologies, 3 showed mesenteric adenitis, and 2 had appendicitis, which one of them was didn't have any clinical suspicion of appendicitis, so was treated conservatively. 15 patients had CT scans, 6 were normal, 4 showed diverticulitis, and 1 showed subacute appendicitis, was treated with antimicrobial therapy. 5 patients didn't receive any imaging, and 8 had ultrasound proceeding to CT scan with following a CT scan. We had 7 patients undergoing a diagnostic laparoscopy, 5 had appendicectomy, and only 2 was confirmed appendicitis on the histology report. Therefore, we concluded that 97% of the patients with a low score did not have appendicitis, and managing patients on an ambulatory basis, that could save the organization about £100,000 in cost. Next slide, please. So to conclude, patients with low AIR score were extremely unlikely to have appendicitis, and low risk patients can be managed on an ambulatory basis safely with significant saving to the organization. Thank you very much.
Thank you. That's a very low incidence of appendicitis, isn't it, in that group of patients? Do you not think it's just been very selective in terms of who you put in the study? First question. And second question, did any of those go on in the next year or so to come back in with appendicitis? Or they're just basically non-specific abdominal pain? You didn't even need your score to assess them.
So, I'm sorry, what was the first question? Sorry.
It's remarkably low level of appendicitis in that group of patients. Is it not a fact that you've just chosen a bunch of patients who had very straightforward non-SAP that basic clinical acumen could have separated out and saved you with your pencil and paper working out their AIR score?
So there was no exclusion criteria in this study. We analyze every patient coming to A&E being reviewed by a surgical team with the right iliac fossa pain. They had the AIR score calculated. Hopefully we did not choose or just focus on the very low risk patients, but it's because the scoring itself is a combination of CRP, white cell count, and the level of the tenderness and temperature. So, and there's a multiple randomized clinical trials studying the AIR score, showing that it's highly sensitive, ruling out appendicitis in the low risk group. And for the second question,
what happened to them for the next year?
Yeah, so for the follow-up, we had only 1 patient coming back to the hospital with pain, normal bloods, and then within 30 days, readmission. And she was discharged with no intervention as well, and no patient represented in 30 days follow-up. So.
Okay, thank you very much.
Thank you very much.
Back to you, Kai. Kai, you're muted.
Now, moving on to the next part of the 3-paper series, we're going to go to the talking posters. And can I invite Edward Nevin, who will talk to us about the 2 very common treatment for anal fissure.
Thank you. Can you hear me?
Yep.
So this is our meta-analysis that I did at James Cook Hospital, which is in Middlesbrough, looking at topical diltiazem versus topical GTN for the management of chronic anal fissure. As you all know, surgical management of chronic anal fissure can result in fecal incontinence, and because of this, topical treatments are considered as first line in favour of surgical intervention. But we know that the rates of healing and compliance with topical agents vary between patients. So the aim of our study was to look at the healing rates, the incidence of major side effects, which is predominantly headaches, and recurrence rates of chronic anal fissure in patients which have been treated with these 2 agents. We identified 9 randomized controlled trials which have been published since January 2000, comparing diltiazem and GTN for the management of chronic anal fissure. and we used a random effects meta-analysis model to compare outcomes. All 9 of the publications, comprising of over 350 patients in each arm, looked at the incidence of healing rates, and it was found to be the same between both agents. 8 of the randomized control trials looked at headache, and they actually found that in all the randomized control trials, headache was significantly more common in the glycerol trinitrate group, which often resulted in failure of completion of therapy. Additionally, we looked at recurrence rates, and recurrence was defined as successful treatment and then to go on in the next 12 months to have recurrent symptoms. And 4 randomized control trials looked at this. And again, the rates of recurrence was significantly less after treatment with diltiazem. So what we've concluded is that topical diltiazem and GTN results in comparable healing rates, but diltiazem is superior with regards to headaches and late recurrence. Diltiazem should therefore be considered as first-line non-operative therapy for chronic anal fissure. And actually the NHS tariffs have changed recently. Previously, GPs used to like using glycerol trinitrate because it costed £39, which was for a treatment regime, which was significantly lower than diltiazem. But now diltiazem ointment in England, the tariff is only £13.44. So we're encouraging our GPs to use diltiazem as first line.
Thank you very much, Ed. I've just got one question. The last time I checked, it might be some time ago, did you know that NICE guidance do not recommend diltiazem as the first line treatment? And what should we do as clinicians?
I did, and actually the reason that the predominant reason that NICE guidance don't recommend diltiazem was that historically it cost about £89 per treatment regime per patient. However, given their, but they do recognise that actually treatment compliance is higher in the diltiazem group due to headaches. So they recommend only using diltiazem if your patient has a headache and can't tolerate GTN. I think that guidance should be revised now that diltiazem ointment is on the market at a much lower value.
Okay, thank you very much, Ed.
Thank you.
Back to Peter.
The next talking post is going from Abu Nahid, talking on endoscopic tattooing for colorectal lesions.
Hello there. Okay, can you hear me?
Yes, we can.
Hi there. Hi. My name is Mohammed Nahid. Yeah, I'm going to present my poster on endoscopic tattooing for colorectal lesions, which actually impacts on patients' care and patients' outcome. So we all know that bowel cancer, colorectal cancer, is the second most common causes of cancer-related death in UK, and BCP is advocating the guidelines about the endoscopic tattooing for suspected malignant lesions in the colorectal areas. Endoscopic tattooing plays a vital role in oncological clearances, especially for colorectal cancers, and especially for early or flat cancers, which becomes really difficult to identify during the laparoscopic surgeries because of lacking of tactile sensation, as well as it is very difficult in open surgeries as well to find out very early cancers to palpate it. So endoscopic tattooing, since its invention, has been trying to be a routine use in the endoscopic unit. However, its routine use has not been achieved completely yet throughout the world. So we did a retrospective analysis, and our aim was to assess the adherence of the tattoo protocol that has been published by the British Society of Gastroenterologists in our endoscopy unit, which is a large district general hospitals in southeast region of England. So the retrospective analysis, we included 252 patients, those who have been referred to endoscopy unit from the MDTs, complex MDTs, as well as from the cancer pathways. We included the patients between January 2017 to December 2018. And our primary outcome of the study was to see that how many of these people are missing to have the endoscopic tattooing during the initial investigations, and how many of them require re-endoscopy to only for the sole purpose of tattooing later on before the operations. We have gone through all the endoscopy reports of the patients as well as their histology reports. We collected data about the patients' tattoo-related complications and number of the tattoos and the placement of the tattoos in relation to the lesions. So among the 252 patients, 88%, which is about 222 patients, who had malignant colorectal lesions, and 12% of them had benign colorectal lesions. So among these 252 patients, we found that about 59%, which is 148 patients, had tattooing, endoscopic tattooing, after being referred from the complex MDT and cancer pathway. Out of these 148 cases, about 46% of the cases, that is about 68 patients, the report was actually completely mentioned about the distance of the tattoos in relation to the lesions, and rest of them there was no about tattoo location was not been mentioned completely or clearly in the reports. Unfortunately, we can see that among all of these patients, about 14.3%, that is about 36 patients who required re-endoscopy prior to the operations. Among these 148 patients, we have also looked at how many of them had proximal, how many have got distal, and how many have got both proximal and distal placement of the tattoos. We see that about 97%, that is 144 patients had got distal tattooing in relation to the lesion, and only 1.5% each had both proximal and distal, and only proximal. So we concluded in our study, our retrospective analysis in our endoscopic unit with that a need of improvement and the uniformity of the tattoo practice among the endoscopists. Despite the BCPSP has published the guidelines, we also say that the endoscopist, all the endoscopists who has been performing endoscopy in our unit need to be in the complex MDT meetings to participate, although they are being from gastroenterologists or other locum gastroenterologists who are being performing colonoscopies. They need to be in the endoscopy, in the MDT meetings in the departments, in the colorectal MDTs. And patients, about 14.3% of the patients who requires re-endoscopy only because of the sole purpose of tattooing, which actually delayed the patient management as they have been referred from the complex MDT and the tattoo has not been placed. So they have been deferred for another endoscopy, and then they have been booked for elective operations later on only because of the tattooing not been performed in the initial investigations. Thank you.
Thank you.
Thank you. Yeah, I accept there'd be a bit of delay there, but I'd be pretty miffed if I was a patient having to have a second colonoscopy to place a tattoo. Any difference between gastroenterologists and surgeons in terms of placement or otherwise of the tattoo? And any difference between the standard NHS hospital and any of these endoscopy providers out in the community, if they have them down in Kent?
Yes. So in our unit, actually, the three categories we have done. So one is the gastroenterologists who have performed the colonoscopy, also the surgeons, as well as those non-substantial endoscopies, they perform the colonoscopy. So we have seen that it is more, the missing of the endoscopic tattooing is more common in the non-substantial endoscopies because they are not very much aware about the guidelines, which has been published by the BCPSP, as well as we have got our local guidelines in collaboration with the main guidelines published by the British Society of Gastroenterologists.
And you flag that up to the local service providers then?
Yes, we have. Yeah, we have done it in local service provider as well.
Good. Thanks, Abu. Kai, back to you.
So next up we have Jessica Gallagher, who will be talking to us about whether laparoscopic surgery, colorectal resection, has any impact on lymph node harvest. Jessica, off to you.
Thank you for the opportunity to present. Lymph node harvest is a key part of colorectal cancer staging. The widely accepted standard is a minimum of 12 nodes per specimen. A greater number of nodes has been associated with a better prognosis. There are conflicting data on differences in lymph node harvest when comparing laparoscopic with open resections, with some studies suggesting there is a difference and some that there is not. This study aimed to assess if surgical access impacts on lymph node harvest and to identify any potential differences between right and left-sided resections. Data were collected on all patients undergoing elective colorectal cancer resections at our trust between April 2016 and March 2018, who were uploaded onto the MBOCA database. Surgical access, the type of operation, and the lymph node yield were recorded. This trust is recognised as a high volume unit, consistently being one of the busiest in England. Over the 2-year period, there were 516 patients, with 301 males and 215 females. Of the 516 operations, 350 were laparoscopic, 126 open, and 40 converted to open. When looking at lymph node harvests, there was a good mean yield for all resections in both laparoscopic and open. All groups had a mean lymph node harvest greater than the minimum standard, ranging from 19.3 to 29.1. However, when looking at the proportion of patients with fewer than 12 nodes, whilst there was no difference between laparoscopic and open in right-sided resections, in left-sided resections, there was a greater proportion of patients with fewer than 12 nodes in the laparoscopic groups. In left-sided colonic resections, this was 13.9% versus 3.9% in laparoscopic and open respectively, and in rectal resections, this was 18.2% versus 10.2% in laparoscopic and open respectively. High mean lymph node harvests are achievable in laparoscopic and open colorectal surgery, and mean yields presented compare favourably with other studies. We found that the proportion of patients with inadequate lymph node yields, fewer than 12, was greater after left-sided colonic and rectal laparoscopic resections, but these data can be lost when mean lymph node yields are presented. Caution must be taken in interpreting lymph node data, and ongoing monitoring is required to ensure minimum standards are achieved. Thank you for the opportunity to present.
Thank you very much. I think your paper highlights the importance of how you can interpret data differently to yield different results. So my question then to you is, what if your ongoing monitoring consistently show that laparoscopic surgery has lower proportion of patients with less than 12 lymph nodes? What would you do?
Well, it's quite difficult because some of the elective patients will have had chemoradiotherapy, so this can impact the number of nodes that are in the specimen. So perhaps centres should present the proportion of their patients with less than 12 nodes alongside the number of nodes that they have in the MBOCA database to identify areas that are consistently having less than 12.
Okay, thank you very much. Peter, back to you.
So for the penultimate paper, back to Tanvir Abbas, who's going to talk about malnutrition and clinical outcomes in patients with operable colorectal cancer.
Thanks for the opportunity. Can you hear me?
Yep.
So this study is basically in keeping with the European Society of Parenteral Nutrition guidelines, and we try to combine malnutrition using a MUS score, which is calculated as the patients are admitted into the hospital, and along with systemic inflammatory score, which we calculated for the purpose of this study from modified Glasgow prognostic score, which is a combination of albumin and CRP. So CRP of greater than 10 and albumin of less than 35 will give a MGPS score of 2. Along with a CT-derived body composition assessment with regard to patient low skeletal muscle index and low skeletal muscle density, and combine them in this patient cohort of around 1002 patients with operable colorectal cancer. The MUS score was available in around 984 patients, and we classified them into low malnutrition and moderate, as well as high risk, depending upon their pre-operative MUS score, which was calculated within 3 months before they undergo surgery, as well as their lab tests, which included modified Glasgow prognostic score, and neutrophil lymphocyte ratio was also analyzed in this analysis. Body composition was carried out from this pre-operative CT scanning and at lumbar 3 level, and low SMI and SMD level values were calculated. And with regard to results of this patient, we had predominantly 80% of patients in a low MUS category, and the rest of around 174 patients were in the moderate to high risk category. The results of this study showed that the patients who are low risk must, when compared to the moderate to high in malnutrition risk, they have got elevated inflammatory markers and in the form of elevated MGPS and elevated neutrophil lymphocyte ratio. They also have a sarcopenia with low SMI and increased amount of fat in their muscles with indicated by the low SMD. All p-values less than 0.05. And MUST was found to be independent prognostic marker of a length of hospital stay and a 3-year overall survival in these patients. We further categorize the patients who are low malnutrition risk with MUST score of 0 into those who have got a elevated MGPS and those who had a MGPS of 0. And we found that the patients who are systemically inflamed, like MGPS of 1 or 2, they had elevated neutrophil lymphocyte ratio. They also had a low SMI and low skeletal muscle density values. Along with that, they also had increased post-operative complications, which was classified as Clavien Indo grade 3 to 5. And they also had a longer hospital stay of more than 7 days and poorer 3-year survival rate. On multivariate analysis and the patient comorbidities in the form of ASA score, MGPS were independently associated with risk of complications, while ASA, MGPS, and NLR were associated with prolonged length of hospital stay. I identified the patients with those who had more comorbidities, those who were inflamed. They also had a poorer 3-year survival rate. The second category of patients were moderate to high risk, which in this study were also further classified in those who were inflamed. And they were giving samples of around 75 and those who were not inflamed. Those who were inflamed, they had a higher comorbidities and they had an elevated neutrophil lymphocyte ratio and had a low skeletal muscle index and low skeletal muscle density. With regard to clinical outcomes, these patients had prolonged length of hospital stay and a poorer 3-year survival as compared to those patients who were not systemically inflamed. In conclusion, a small proportion of patients with operable colorectal cancer were deemed to be a low risk as defined by the MUST score. The systemic inflammation in the form of elevated MGPS or elevated neutrophil lymphocyte ratio was associated with sarcopenia and myositis and also poorer clinical outcomes. We think that systemic inflammation plays an important role in nutritional assessment of these patients undergoing surgery for colorectal cancer. Thank you.
Thank you. So if I have any of these patients at higher risk, what should I do about them, apart from warning them about the increased risk of complications?
So there is various modalities can be used. The patients can have exercise training and to build up their muscle mass, as well as in the use of anti-inflammatory diets like omega-3 fatty acids diet, and the patients like use of anti-inflammatory drugs, which is also being tried in order to improve their preoperative assessment and optimize them before surgery.
So identify them and follow that advice.
Yes.
Super. Thank you very much. Kai, back to you for the final paper.
Thank you. Can I just check, do we have the last paper of that's been withdrawn? So we do have.
No, yeah, we do have Tanvir Shan's going to speak, and then the last one's withdrawn, so we've still got one more.
So we do have next one then from Tanvir then on virtual versus optical colonoscopy in bowel cancer screening. So off to you, Tanvir.
Hi, good evening, everyone. Thanks for the opportunity to present my work. Optical colonoscopy currently remains the gold standard for evaluation of both colorectal cancer and colonic polyps. However, it's an invasive and expensive procedure and not always suitable for elderly or comorbid patients, particularly patients with cardiorespiratory or mobility issues who can't lie flat for the procedure. Even in the best of hands, there are significant risks associated with colonoscopy, including perforation, and these risks are well known in communities and have actually, studies have shown that this has led to reduced rates in patient in the bowel cancer screening program. Virtual colonoscopy, or VCT, has emerged as a reliable alternative, non-invasive for the bowel cancer screening program, particularly where polyps are detected at greater than 7 millimeters, And studies again have shown that this has led to higher participation rates in the BCSP. Rather colloquially asked one of our radiologists how good at our smaller centre we were at identifying these polyps on VCT, and they asked me to subsequently do this. In this was to compare the reliability of VCT versus traditional colonoscopy at our centre for detecting polyps following a positive stool sample in the BCSP. Quite a simple methodology. We literally looked at a review of our database of the VCTs performed in the year from 2018 to 2019 in January. We compared the radiological reports to any subsequent follow-up endoscopic reports and subsequent histology. You can see on this diagram a polyp which has then been reconstructed in the 3D modality, and then the appearances of that polyp at colonoscopy. In total, within the year at our centre, we performed 90 VCTs, and we do not report any adverse events. 20 of those 90 were reported as having a clinically significant polyp. 19 patients elected to go on to have colonoscopic evaluation for polypectomy or biopsy, with one patient refusing to attend for health reasons, and all of those did end up having a clinically significant polyp. 6 of the 19 also identified a polypoid or sessile polyp, all which were documented as being less than 7 millimeters. And 1 out of those 19 went on to have a tubervillous adenoma, which at histology was found and was not seen on the primary VCT. This study adds to the available evidence that VCT is safe and reliable for colonic evaluation following a positive BCSP result. It's safe and well tolerated in particularly elderly and comorbid patients. And whilst there is a risk of missing polyps less than 7 millimeters, a recent systematic review has shown that this is an acceptable omission rate, as only 1% of those polyps will go on to become malignant if they are less than a centimeter. Thank you.
Thank you very much, Tanvir. So based on your results then, would you not recommend that all positive bowel cancer screening patients should have a virtual colonoscopy rather than a colonoscopy then?
Absolutely. Well, I wouldn't necessarily myself recognise, but there's certainly more and more centres of VCT as primary diagnosis following a positive result. I suppose the only disadvantage is obviously that with identifying possible histology and polypectomy, you need that colonoscopy. So I think that's the only thing really why VCT hasn't overtaken colonoscopy yet. But certainly as a screening tool, I think it's a valid option.
Okay, thank you very much. So I think that will conclude our free papers session today. Is there any questions from the panel, from the speakers, from the participants? No? I think we've been reminded that we would like to invite you to view the e-posters. As you can see, the URL is there. And I think we've also been asked to remind you that tomorrow there's an equally fascinating session on colorectal topics as well. So if you found today very useful and fascinating as much as I have, I hope you will log into the webinar tomorrow, same time, same place. Anything to add, Peter, from your end?
No, thank you to all the speakers. Thanks for keeping to time, and I hope you all enjoyed it. Have a good evening, and we'll hopefully see you tomorrow.
Thank you very much. Bye-bye.
Bye.